Yes, thank you, Ria, and welcome everybody who logged in. So I have my my slides ready. So Ria gave, so just to allow me a moment to elaborate on some of what Ria said. So I'm a clinical pharmacist, like she already mentioned, and in the community. So that means I don't work in a hospital. I also don't work in a pharmacy. I work, my role as a clinical pharmacist is to assist physicians and their patients with disease and medication management. So patients are referred to me by physicians, by family members, and sometimes by self. And patients who are older than 65 years old, I usually allocate to senior care practice. And those patients with diabetes, I allocate to diabetes care and wellness practice. And the reason for that is that senior patients older than 65 who do not have diabetes may not identify with diabetes care and wellness practice. And for this, by the same token, people who are younger, because in my diabetes practice, I see patients as young as 19 years old to as old as 100 years old, and they may not identify just with senior care practice. So apart from being a pharmacist with advanced training and certification in diabetes, I also have training in pain management in the elderly and in cognitive behavioral therapy. So cognitive behavioral therapy's abbreviation is CBT. And for those of you who are not familiar with cognitive behavioral therapy, it is a non-medical, so not a pharmacological treatment approach that addresses the ways people think and behave that affect their health in a negative way. And so, and in other words, what I mean by that is so people's bodies can respond with symptoms, and often these symptoms are treated with medications. And CBT, we teach people strategies, and we give them tools and we give them knowledge to change the way they think. And in that way, many times we resolve the symptoms, and we have evidence in specific areas with CBT treatment, and that is anxiety, depression, insomnia, and chronic medication disorganized eating, which is another word for cravings. We know that this treatment option is effective. Is this a good time to go ahead, Ria?
I muted myself. Yeah, go ahead. You can start.
Sure. So the objective of my talk tonight is to familiarize you with the concept of deprescribing, of the possible alternatives and the positive outcomes of deprescribing. And to appreciate deprescribing, I'm going to walk you through some of the data that's published by the Canadian Institute for Health Information, the Institute for Safe Medication Practices, and Canadian Public Health Agency. So I'll also walk you through a case study to demonstrate the principles of deprescribing. We'll talk about some of the myths and the alternatives, and we'll wrap up with a summary and a question and answer session. So to get us going, I'm going to introduce my patient John to you. John is a patient in my practice. He's 86 years old and he lives with his wife in the community. He's been hospitalized 3 times in the past with stomach bleeds. He's received blood transfusion all 3 times. He had a number of falls, and his family was concerned about his health that was deteriorating fast and the frequency of the hospitalizations. So John had a significant cardiovascular history that includes hypertension, high cholesterol, heart failure, fibrillation, which is not uncommon in an 86-year-old. He had chronic low back pain, osteoarthritis of the left hip, and prostate cancer that was medically managed. So he's followed by a family physician, cardiologist, a neurologist, and a cancer specialist. And he takes 14 medications, 3 are prescription medications, 1 over the counter. So in other words, a total of 16, he takes a total of 16 pills a day, 7 in the morning, 3 with lunch, 4 with supper, and 2 at bedtime. So when I interviewed John, he complained of uncontrolled and unresolved pain of the left hip. So uncontrolled, this means the medications that's been prescribed for him is not effective. And unresolved means this is just going on and on. So by the same token, he also complained of unresolved chronic back pain, painful and frequent voiding, constipation. He said he's fatigued during the day, he's lethargic. He complained and said, I'm taking too many medications. It's impractical. It's an impractical regimen because sometimes when he wants to go out in the middle of the day, you may recall that he had the 2 medications with lunch. He said it's impractical. Sometimes I want to go out and I don't want to take my medications with me. So sometimes he forgot to take his bedtime dose because he said I fall asleep in front of the TV. He complained of muscle pain in the lower extremities and lack of mobility and physical activity. So when I assessed his case, I found that he had multiple medications that contributed to his bleeding risk. He took medications that was prescribed by his physicians in addition to the one over-the-counter medication that he took. He had the antiplatelet medications that was prescribed by his doctor was an inappropriate dose. John had also low blood pressure that may have contributed to or lead to the falls that he had. He is dehydrated. He had something that's called diuretic resistance, and yet his pedal edema was not resolved. His heart failure regimen was inappropriate. He also had osteoporosis that was not diagnosed at the time or managed, and his vaccinations were not up to date. So with John in mind, let's move to the data that I mentioned earlier. So in Manitoba, data shows us that 3,000 seniors die each year due to adverse drug events, of which 88% are preventable. The data also shows us that 11% of ER visits by seniors are drug-related. So in 2016, Canadian Institute for Health Information announced or released a publication in which they claim that 1 out of 143 seniors was hospitalized due to medication-related problems. Seniors are hospitalized 5 times more often than people younger than 65. And experts in the area of geriatrics claim that medication-related problems is the 5th leading cause of death in older individuals. So the previous slide may suggest to us that medications are bad. We should not take them. And that's actually not true because we know that medications for chronic illnesses like diabetes and hypertension, high cholesterol, pain, mental illnesses, they control symptoms. They save lives. The literature also sometimes talks about morbidity and mortality, and it improves the quality of life of people. So we know that older people have more health conditions because of aging. They take multiple medications, and sometimes they have multiple prescribers. Now, on the other hand, although this may be true, on the other hand, every medication has benefits and potential risks. And so it's important for us to know that or consider the fact that medications are powerful technologies. So in the 1700s, there was a wise and experienced family physician, Philippe Piner, and he suggests that it is of no little importance to administer medications properly, but it is an art of much greater acquisition and difficult acquisition to know when to suspend altogether, or to suspend or omit altogether. So I titled my presentation, "What was good in the past may not be good now." And here are the 4 reasons why. So first of all, did you know that aging changes the body, and that aging process starts at age 25? So it's at a very slow rate. But by the time a person reaches the age of 65, that aging and the changes in the body accelerates. And by age 80, the acceleration or the changes takes place at a much faster rate. And the four main areas in the body where these changes take place, first of all, is in the brain. So the brain becomes more sensitive to medications that have an effect on the brain tissue. As we age, we also lose lean muscle mass. In other words, our fat tissue increases. So medications that accumulate in the fat, or fat soluble for that matter, can become more easily toxic. And the toxic that I'm talking about is also referred to as side effects. So because we lose lean muscle mass, we also lose volume. So medications that are water soluble accumulates in the smaller volume that's in the body, and also can become toxic, or like I said, another way to describe the toxic concentration is to say that it presents with more side effects. The liver is the organ in the body that breaks down medications. And as you can imagine, as that slows down, medications that are broken down by the liver can accumulate in the body and also present with side effects. And then the kidneys also slow down, and that's the organ that excretes medications. So medications that are excreted by the kidneys can also accumulate in the body as the kidneys slows down. So that is the reason why some medications can become risky or called inappropriate, and we'll talk about that in a moment. So another reason why what was good in the past may not be good now is because our circumstances may change and health conditions may change. I'll give you examples of that. So in my practice, I often see someone, for example, that may have lost a spouse or had another traumatic life event. And for a period of time, that person was grieving, or the person had difficulty with anxiety, maybe with insomnia. And so it's appropriate to prescribe a medication to help this person, tide this person over. But often I see in my practice people who are still taking that medication 5 or 10 years later, even though those circumstances and the reason why the medication was prescribed in the first place does not exist anymore. Other times I see, for example, the health conditions change. For example, women who have been treated for menopause in the early 50s. I see many older individuals, older women in the 80s still taking the menopause medications. So another reason is that best practices and guidelines change as research evolves. We learn more about the diseases. We develop different approaches to manage diseases and conditions, and also our treatment options change. And so lastly, some medications become unnecessary. For example, the guidelines, due to guideline updates, we know now, based on the research that we have, that it is not necessary to treat all the individuals, so I'll rephrase that. It's not necessary to treat the hypertension and high blood sugar in all the individuals with too many medications and otherwise according to tight targets. So what this slide the information here wants to convey is that medications should reflect the changes in our age, our circumstances, and also in our practices. So I talked about earlier about polypharmacy. Polypharmacy, as you may be familiar with, is when a medication, a person presents with side effects. I mentioned earlier that sometimes because medications accumulate in the body, it presents with side effects. Let's say someone has been prescribed with a medication in their 40s. They're now in their 80s. So because of the changes that took place, the medication accumulates, now present with side effects, and these side effects are considered a new diagnosis. And as you can imagine, sometimes it is treated with a new medication, and that's called the prescribing cascade. It's also referred to as polypharmacy. So I'm not going to go into the details of polypharmacy because there was a talk last fall in a FIT talk on the topic of polypharmacy, and I believe it's easy to access that online. I included the slide just to remind us that polypharmacy is a regular use of 5 or more medications, including topical medications, inhalers, over-the-counter, herbal and natural remedies, because and that we are worried about the consequences. The consequences are the adverse drug events, or we also call it unwanted incidents that may affect the functionality, the independence and the quality of life of people. And these consequences, for examples of the consequences, are falls and fractures, cognitive impairment. People describe decreased inattention, loss of language and decision-making, computing and thinking skills, difficulty to remembering, a difficulty to concentrate, and a sense of fogginess. So polypharmacy also leads to non-compliance. That means not taking medications as prescribed. Now, if you think back of our patient John said to me, I'm tired of taking all these medications. Sometimes I'm not taking my lunch medication. Sometimes I don't take my bedtime medication. So let's assume for a moment that one of the medications that he was supposed to take at lunchtime was for his blood pressure. So as if he misses too many doses, his blood pressure may be higher than what was safe for him. And and let's say he'd visit his physician and his blood pressure showed high, the physician would perhaps, or most of the times, prescribe another medication. So on the days when John takes all his medications, he may have low blood pressure and become dizzy and may have falls. So we already talked about hospitalization. I show you the data where people 11% of hospitalizations of older individuals are due to medication related. We talked about the deaths that's attributed to medication use, and also one of the consequences of polypharmacy is reduction in quality of life. So I mentioned in one of the other slides that some medications become risky and potentially inappropriate. So a medication is called risky and potentially inappropriate when the risk of the drug-related problem outweighs the benefits, and when there are alternatives that are safer with the same or greater efficacy. So examples of the risks, or we can also call it harms, that we talk about are accidents and injuries, sometimes due to blurred vision that's caused by some medications, dizziness and balance disturbances that are common among older people who take certain medications, also memory impairment, urinary incontinence and constipation. So some medications make the bladder lazy, and that leads to urinary incontinence. Some medications, a combination of medications, lead to constipation. So a benign outcome of constipation is just bothersome hemorrhoids. It can be more serious and cause diverticulitis, or even more serious and cause impaction. So examples of drugs that we consider risky or potentially inappropriate, where there are safer alternatives, are oral anti-inflammatories. That's one of the drugs that John took. He took it to control that uncontrolled hip pain, but it had an effect on his blood clotting, and that's why he ended up with, part of the reason why he ended up with the bleeds, stomach bleeds. So antipsychotics are also considered risky medication, long-acting type 2 diabetes medications, anti-allergy and anti-itching medications, sleeping pills, anti-anxiety, anti-reflux, and the narcotic opioid analgesics. So to put the healthcare cost of risky and potentially inappropriate medications in perspective, it costs $1.4 billion every year to treat these harmful effects that's caused by risky and potentially inappropriate medications. So far, our conversation, or the theme of our conversation was around aging, multiple conditions, and multiple medications that people take. But the experts in deprescribing also claim or blame the poor data that I showed you on the way that we practice. So they say that, so some of the reasons, I've outlined some of the reasons, as they say that as we gain more evidence and the research evolves, we discover more diseases, we develop more clinical guidelines, we develop more screening methods, and that may lead to overdiagnosis, overtreatment, and polypharmacy. The diagnosis of sometimes side effects is diagnosed as a new problem. It's treated with a new medication that lead to overdiagnosis, overtreatment, and polypharmacy. Sometimes we do not include patients in our decision making. So my example of John is that he was diagnosed with osteoporosis, but he chose not to be treated by one of the common pharmacological treatments. He just wanted to be treated with vitamin D. So sometimes because we do not include patients in our decision making, that may lead to overdiagnosis and overtreatment. Physicians are generally hesitant to change medications that are prescribed by other physicians or by specialists, which is a very valid point. And sometimes physicians are not well versed on non-pharmacological treatments, or maybe they do not have confidence in or much experience with it, which is also a valid reason. So the second point here is that we live in a medicalized social environment. And that means that there are the belief, some people believe that there's a pill for everything. For every problem, medical problem, there's a pill, and that's not always the case. And sometimes physicians feel compelled to write a prescription. So the next point says that routine medication review is not done in clinical practice. So that means in physicians' offices many times, or majority of times, physicians do not review the medications on a regular basis. In other words, ask the questions, was this patient taking the medication? Is that problem, does it still exist? Is the person still symptomatic? Is it still prescribed in the right dose? Maybe look at the kidney function. So, and often physicians have the notion of don't fix it if it's not broken, which may be a valid point. We'll look at that a little bit later. So as you know, we also have time constraints in clinical practice. So many physicians allow 10 to 15 minutes or one problem only. So that may lead to overtreatment and overdiagnosis and overtreatment. And the deprescribing guidelines, deprescribing as the short definition for deprescribing is, it's the opposite of prescribing. So the guidelines are relatively new, and therefore many physicians have limited experience with deprescribing. So deprescribing, as I said, is the opposite of prescribing. So let's look a little bit in more depth into what this is all about. So deprescribing is a process. It's systematic. That means that it is done step by step. And it's also done supervised. So that means it is overseen or initiated by a health professional. It's based on guidelines and on evidence. And the way we go about is by tapering. That means we lower the doses of medications, or we may reduce the number of medications, or we may stop medications altogether that are no longer effective, may no longer be needed, may no longer be safe, or may no longer be the best choice. So the objective of deprescribing is to reduce the medication burden and risks that we already talked about and optimize the wellness and quality of life of people. And we've learned that with older individuals, less medications mean more quality of life for them. So when I talk to physicians and to patients about deprescribing, I often hear objections. So a patient may say, my doctor prescribed this medication and it must be all right. And the physician may say, well, if it's not fixed, if it's not broken, why would I fix it? And my answer to that is, well, is it not better to prevent a broken hip than trying to fix it? So sometimes prescribers say, well, deprescribing may lead to the return of symptoms. And my answer to that is, well, it may or may not, because whether we prescribe or we deprescribe, we have no guarantee. So if the symptoms do not return, it means the person doesn't need it. If the symptoms return, we just restart it, or we use the opportunity to explore safer alternatives. So in the bigger scheme of things, we have nothing to lose. We can potentially only win. Sometimes, sometimes physicians would say, well, what's the evidence that deprescribing is safe? And my answer to that is that the Canadian Deprescribing Network is a leader in the area of deprescribing, and it's also a member of a global initiative where researchers combine their findings and their research, and they provide clinicians with evidence and guidelines based on the evidence, practical tips and resources, and I included the website in case you're interested to look at that. So sometimes patients, physicians say, well, my patients are reluctant to engage in deprescribing, and that's also not true, because in surveys that have been done amongst all the individuals, 70% of seniors said that they're willing to reduce their medications if it's done gradually. Gradually, I mentioned earlier, deprescribing is done step by step. If it's done in a safe manner, which I showed you, deprescribing is done as overseen by a health professional. It is also based on clinical evidence and according to guidelines. And older people say, well, we're willing to become engaged in deprescribing if there's an appropriate monitoring, which is also part of the deprescribing process. So 3 things that seniors can do to ensure that you're treated with the least number of medications and the safest treatment options is to ask yourself, are you taking too many medications? You can ask your physician, are you taking unnecessary medications or risky medications, and initiate the conversation about deprescribing, or you can consult a medication and deprescribing expert. So I listed examples of questions that one should ask for each medication. So you want to know, why were you started on the medication? What was the problem? And how will you know that that problem still exists? And is it possible to reduce the dose of the medication that's treating it, or maybe stop it? What will happen if you reduce the dose or stop it? Is it safe for someone your age? Can it affect your memory? Can it cause falling? The harm and the injury we talked about earlier. Is there perhaps a safer alternative? Or maybe there's a non-drug alternative. Does the medication produce side effects that's treated by another medication? And is it possible to reduce the number of medications that you take? Well, some of the alternatives that I mentioned earlier that are evidence-based, clinically proven, to lower the pill burden and stop risky medications, we have over-the-counter medications that may be as safe, may be safer or with equal or greater efficacy as the oral medications. Sometimes topical medications are safer than the oral versions, and they may be just as effective. Nutrition therapy means food can be medicine. So we know that in diabetes, hypertension, and high cholesterol, adjusting a person's diet can lead to improved symptoms, can improve numbers, and therefore often we're able to stop some of the medications or reduce the doses. People who have weight to lose or maintain a healthy body weight, for example, in the case of diabetes, hypertension, high cholesterol, and even acid reflux, we know that if someone loses weight, that we can often reduce the number of medications or the doses of the medications. Some lifestyle interventions are good alternatives, evidence-based alternatives, such as regular physical activity, helps people with hypertension, high cholesterol, with diabetes. Physiotherapy can help people with bladder problems, people with dizziness, people with muscle and joint pain problems. engagement in social and new learning activities, adequate natural light exposure, time in nature, meditation, and quality sleep help people with mental illnesses, people with anxiety, insomnia, and depression. And as I mentioned earlier, cognitive behavioral therapy has been proven to be effective in people with anxiety, depression, insomnia, chronic pain, and those who have food cravings. So to wrap up, let's see how, after all of this, how John is doing. So just to remind you that prior to the intervention, John took 14 oral medications. 13 was on prescription, 1 over the counter. He took 16 pills a day because some of the medications had to be taken twice a day. 7 in the morning, 3 with lunch, 4 supper, and 2 bedtime. And now, after 9 months and multiple medication changes, John only takes 5 oral medications and a total of 8 per day, because some of them have to be taken twice a day. He takes 4 with breakfast, 4 with supper. We added that vitamin D, a once a week tablet to treat his osteoporosis. We reduced his pain medications and replaced that with an injectable every 6 months. And John also practices cognitive behavioral therapy to help him manage his pain symptoms. So 5 messages that I'd like you to take home today is that medications is a powerful technology. Think of other technologies like heavy equipment. Well, you have to know what you're doing when you use that technology, and the same is with medications. So deprescribing is an innovative approach to address the negative impact that prescribing cascade and the polypharmacy, inappropriate medications have on people's health, while it improves the quality of life of people. So I'd like you to also reflect on your own medications. Ask valid questions, go through the list perhaps that I've given you, or seek the input from an expert. So advocate for your own health, but never change your medications or stop it without consulting your health provider. So in my practice, I work with my patients' family, their physicians, the other health providers. I'm an advocate for my patients. I've also over the years built a referral network, meaning that I refer to other health providers who are experienced and trained in the area of geriatrics. I know that they care, so I feel confident to refer to them. I used to do house calls prior to COVID, but right now I do see patients in my office. I also do virtual appointments, and my fees are tax deductible. It's covered by insurance plans with extended healthcare benefits, and I've put my contact information there on the screen, on the bottom of the screen. So thank you for your attention, and feel free to ask questions.
Thanks, Mathilda. That was a great talk. I'm just going to put it so I can see some people's faces here. Hang on. So if anybody has any questions or comments, again, you can use the chat box. I know when I heard this, I think the take-home message was the example she used of the patient that, you know, that individual had so many medications and maybe some of them were interacting differently. And then after that, you know, going through that process that they were able to reduce that. So I thought of lots of people in my life that maybe were on many medications at one point. And it's good to know going, you know, as we all get into different stages of life, that as we get prescribed things, maybe to ask those questions, right? Why am I on this? Is it beneficial? Does it work with all the other stuff that I'm taking? So if anybody has any questions or comments, again, you can put them in the chat box there. I'm just going to, I don't even have it. Our next talk is next week, Tuesday. And I'm kicking myself because I can't think of the title off the top of my head, but it'll be advertised. And if you're coming into the center, you'll see it on the screens. I don't have my paper with me. But anyways, I will give everybody a minute or two. If you don't have a question or anything, thanks again for coming out, spending your Wednesday evening with us. I have to remember what day of the week it is. Thursday evening with us. I hope everybody enjoys the weather. We're supposed to have a great weekend, so try and get out there and do some activity, enjoy the sun. We seem to get it for one day and then it disappears for another couple after that. And I'm going to thank you again, Mathilda, for joining us. So it was a great presentation. Oh, there is one comment. Oh, someone's asked. Yes, understanding back pain is next week. Thank you very much. That's with Glenn Bergeron. So he was a presenter we had a while ago that talked about knee pain. So he'll be back next week. Thank you, whoever was helping me out there. If anybody has questions, again, comments there, I'm going to thank Mathilda. And I don't see any burning questions. So I think everybody's just absorbing all the great information you gave us. And I hope everybody has a wonderful evening. So thank you, everybody. Oh,
have a good night.
Last minute question. We're going to catch it in. I was advised to take a second med on top of one that wasn't working and to keep this first one. It doesn't make sense. So I'm guessing that's kind of a comment to you. I'm not sure if you can answer that, Mathilda. It might be maybe that you need to double check with your pharmacist and see kind of what's going on there, or go back to your doctor to see what the medication is for, and that they know maybe that you already have one for that problem. I'm not sure if you can add to that, Mathilda.
Yeah, I think sometimes there are conditions that have to be managed by more than one medication, but I think it's valid to ask for the reason and explanation. So why is that, and what would happen? Is there not another option that's perhaps more potent, where you can just take one medication as opposed to a dual therapy?
Okay. Great. So I hope that answers some questions, and I will say good evening to everybody, and I will see you again next week. Thanks, and have a great weekend.
Good night, everyone.